Am I audible, ma'am? Hello.
Yes, you are audible.
A very good evening, all. I welcome all the esteemed delegates and our speaker to our sixth series of
Am I
our
audible, ma'am?
court. Just a second, ma'am.
Hello.
Yes, you are audible.
A very good evening, all.
I guess
I welcome all the esteemed delegates.
भावना ये तेरा हमेशा होता है.
A very good evening, all. I welcome all the esteemed delegates to our sixth series of Core Connect Visual CME series by Dr. Sunita Tandulwadkar. Let's all join our hands together and start this session with the lighting of lamps.
Have you started the recording and relay?
Yes, ma'am.
Why was the problem of echo? You start.
Now, I would like to introduce our speaker who does not need any introduction herself. Dr. Sunita Tandulwadkar is the head of the Department at Obs and Gynae and Chief IVF and Endoscopy Center at Ruby Hall Clinic, Pune. She is also advisor and consultant at Dr. D.Y. Patil IVF and Endoscopy Center, Pune, founder and medical director of Solo Clinic IVF, a center for excellence in infertility in Pune, founder and medical director of Solo Stem Cells, a stem cell research and application center at Pune. She has extraordinary achievements as India's first stem cell baby and world first at the age of 45. She has achieved it on 16th of April 2018.
Bhavna, can you allow me to share the screen? That's okay, beta.
Okay, ma'am.
Your recording is on?
Yes, ma'am.
Okay. So the relay is happening?
Yes, ma'am.
We are on, right?
Yes.
Okay. So I start the lecture. Thank you, beta. Thank you, Core Connect, for always being there. Dipesh Bhai, Vasu sir, and the entire team with Bhavna who takes in really efforts. And I really love their innovative ideas of recording and ensuring that the link is shared with everyone. So thank you so much. Friends, I always say, don't limit your challenges, challenge your limits. Each day you have to strive for a constant, never-ending improvement because every day we face different types of varieties of patients who comes to us with tremendous hope. And one of the category is recurrent pregnancy loss. So today we will see what are the recent updates. It's a vast topic. Individual topic in its subtopic can become itself 1 hour lecture itself. But I'm trying to overview the entire. The two questions people ask always, or they think themselves, the lady asks, why me? It's very, very difficult to answer why she. And then the other difficult question she asked it, will it happen again? I have gone through the loss or the losses, and will it happen again with me? The loss of a pregnancy at any stage is devastating experience, and particularly sensitivity is required in assessing and counseling this couple. You need to give enough time for this. What I mean by this is when you take a history and when you know it is a recurrent pregnancy loss, you have to give enough time. Sometimes you know that you may not need so much information, or you have to ask so many painful questions to the lady to dig out her complete history of abortion. And it's important that with same enthusiasm and empathic way, we listen to her, what she wants to say. The first literature describing women with the RPL dates back early 1930s. Malpass identified as abortion sequences. And the first definition of RPL was 3 or more consecutive losses prior to 20th week of pregnancy. And it was also labeled as repeated early spontaneous pregnancy vestige in 1983. As such, there is no international consensus regarding the definition, what ISHRE, ASRM, and RCOG says. ISHRE guidelines says up to 24 weeks to consecutive or non-consecutive. ASRM believes in consecutive, but usually by 10th week, while RCOG guideline, which had been from 2011, no updates after that, they have said 3 consecutive. But what is important is in RPL, we don't consider ectopic pregnancy and molar pregnancy. Now, if you consider that RPL, it may be a primary, this patient never had a live issue, or it may be a secondary when she had a live issue followed by abortions. The exact prevalence is very difficult to estimate, as both the numbers in numerator and denominator very difficult to obtain. But it has been reported that RPL approximately affects 1 to 2% of a woman when we do 3 consecutive losses. Adding biological losses, it increases to 2 to 3%. If you say 15 to 20% of the clinically detectable pregnancies, they abort. 5% of the women have RPL that is more than 2, 1% more than 3, and the risk increases. This is important because this is the question patient asks you. 10% after each abortion, her risk is increased. An estimated risk being 24% after 2 clinically recognized losses, 30% after 3 losses, 40%. I always tell my girls to remember by word 2, 20, 3 losses, 30%, 4 losses, 40%. Because it's very important that patient will ask you, what are my chances of having continuation or having loss? And we should be knowing that. Now, second question they will ask is, what is the cause? And if you see in 50 to 75% of the women, it's very difficult to find the cause. What are my chances of having a successful pregnancy? As I told you, the percentage already, but about 65% of the women with unexplained pregnancy losses will have a successful next pregnancy. I'm talking about the unexplained RPL. So, patient frequently asks, they come to you for second opinion. Probably they were getting treated with someone, they had the losses, and they come to your doorstep. It happens with every gynecologist. If they happen with me, they will go to someone else for an opinion. And if they happen to somewhere else, they will come to me for a second opinion, unless with every loss, you sit and counsel and discuss with the patient. You understand the patient is going to leave you. These couple often undergo then, when they come for a second opinion, probably every doorstep, they undergo extensive diagnostic testing. And they are being offered treatment option which doesn't have a scientific rationale. Practice variation can be resolved by implementation of evidence-based guidelines so that we don't do unnecessary too many investigations to the patient. It's very important. One has to identify the risk factors. Lifestyle, risk factor. You know that one first thing is we have to tell the patient the pregnancy loss is lowest at the age group of 20 to 35. It is also, we need to tell her as the age advances, the chances of aneuploidy embryo and hence the loss will be more. Maternal obesity as well as significant underweight, malnutrition, both are equally responsible, and healthy normal range BMI they should work for. Coupled with the RPL should be explained that excessive alcohol consumption, stress factor itself, smoking, all that can affect, and they should be taking care and changing their lifestyle. Now let's see how the causes, but during the causes only I'll try to explain the investigation and management also. As I say, idiopathic is majority, equally known, they are different. One, parental chromosomal anomaly, anatomic defect, autoimmune, hormone, endocrine problem, and many. Don't forget the epigenetics. This is very important. The epigenetics means during the formation of an embryo, the embryo undergo through the stress, and that can cause mutations. And this is not necessarily the ART, even in normal natural conception, this can happen. I don't need to tell the Barker's hypothesis. Usually, for those who are students, they should know the rib cage in the causes. They can easily, they remember it. But usually, I don't like to talk about this. In 2 minutes, I'll explain when I take a history of the patient. It's very important for me to ask one, duration, at what duration, gestational age. Second, whether there was a cardiac activity and baby was growing very well, and then there is a loss of cardiac activity, because this is very important, can lead it to think about what may be the probable. If it is happening at 6 weeks, 7 weeks, genetic causes, yes, very high chance. Uterine septum or the uterine anomaly, yes, there may be. Baby was growing beautifully, and at 8, 9 weeks, 10 weeks, they suddenly find the loss of cardiac activity. Immunological causes, more probably you should be thinking about. Thrombophilias and all will give a losses around 14, 15 weeks. So if the patient is having 7 weeks, don't do the thrombophilia testing for those patients so early. So you need to know more. Of course, incompetent os and all, penless abortion history, it's important. Now, about the uterine factors, congenital uterine anomaly, 10 to 15% of women with the RPL may have it. Septate uterus is most common. Probably longer the septum, worse the prognosis. Subseptate uterus or a complete septum, depending. Then how do you diagnose this? Simple 3D sonography. I don't think we need an MRI or a hysteroscopy to diagnose the uterine anomaly. Anyone who can see that. Now, for example, this, you can make out. It's a complete one fundus and it's a V-shaped of your fingers. And this is a septum. While for a bicornuate, you have a 2 uteri and they have obtuse angle and not the acute angle here as seen. Unicornuate uterus, T-shaped uterus, and partial subseptate. So unicornuate uterus, probably septate uterus, yes, you can think about working on it and you can think about removing the septum uterus. I'm not showing, every one of you have seen n number of videos for the septum uterus. Unicornuate uterus, I would like to spend some time with. This, what is the basic problem in unicornuate is decrease in the volume. So every time they have abortion with increasing gestational age, because with every abortion, there is an increase in the volume and the uterine myometrial hypertrophy. So I started thinking, this is an award-winning paper in 2007. Unfortunately, there is no series or there is no evidence to suggest that you should be doing it. But the thought process came in mind is, it is just the tubular cavity I need to convert into triangular. Today, the word lateral metroplasty, central metroplasty is used so rampantly, but that time we never used to use this word. And I used to think about why not, if the sonography shows me the wall here is quite thickened. Can I just do the conversion and convert the tubular cavity into the triangular cavity? The problem I used to think about is creation with your endoscopic scale. You can. In 2007, we had only estrogen and progesterone. Can I regenerate the basal endometrium? Can I maintain this cavity? And we started working on it. And if you see, this is a unicornuate uterus. This is an unedited video of 2 minutes. It's so simple. One always remember in hysteroscopy, cornal opening is your mark. I take usually the blunt scissor for Syniki or for this case because sometimes your bold, strong make can cause a perforation and can spoil your entire obstetric career. So what I'm trying to do is I'm giving a vertical cut. Give a very good intrauterine pressure so that you are always in the center. And the cornal opening helps you to decide where is the fundus. Now, once you think that you have reached to the fundus, this is a small portion I'm cutting, otherwise it will become a central septum or an arcuate uterus type. And then I'm going laterally. Now, this is supposed to be the cornal opening if it would have been normal. If you see how nicely the cavity is opening on its own with the intrauterine pressure. So you should always do fiber by fiber dissection. It doesn't take a long, and you should be assessing the cavity repeatedly by going at the internal os and seeing. Now you can make out the white cavity, which I have created just now, and the pink cavity. Now this cavity, whether there will be a basal endometrium, whether it will reform. So we give a patient estrogens and progesterones. And I'm just decreasing the pressure to show you that the blood flow is going to be very good. It's not the fibrous cavity. It's a healthy myometrium you have worked. And I have made nearly more than half the uterus there. And down here is a second look. Definitely, if you start thinking about this was a cavity before and this is a cavity, it is definitely more roomy. There is a nice endometrium which has formed. There is a vascularity. What I can do more is I can still make it more cuts and make it. Apart from the uterine anomalies, adenomiotic uterus or the fibroid uterus, why adenomiotic can give sometimes is because they can cause inflammatory changes in the endometrium. Actually, it may give an implantation failure, but sometimes it may give you a RPL. Otherwise, oligohydramnios, IUGR, is the phase in which patient land up in her pregnancy period, while the fibroids, which are distorting the cavity, may be. Intrauterine adhesion, we all know, will give either amenorrhea or infertility, but sometimes there may be insufficient endometrium and this patient can have a RPL. Defective endometrial receptivity. This is likely to be because the endometrial receptivity is defective, either prepone or postpone. If it gets implanted during that, naturally it is going to give an abortion. But I feel more of a biochemical pregnancy than anything in the changed receptivity window. Coming to the immunological factors. Each step in the establishment of normal pregnancy has been implicated as a possible site of an immune-mediated reproductive failure. Both autoimmune and alloimmune mechanisms have been proposed. What does the evidence says? The ISHRE guideline says that women with the RPL, we recommend screening for antiphospholipid antibodies, lupus anticoagulant and anticardiolipin antibodies after 2 pregnancy losses. So you can think about doing antiphospholipid antibodies, that is ACA, lupus anticoagulant, and anti-beta glycoprotein antibodies. So these are the laboratory. Patient will have a thrombosis, either arterial, venous, or small vesicle, and pregnancy-related morbidities are unexplained infertility or premature or maybe a IUD as well. So this is a cascade of a sequence. That's why I said every cause itself can be a 1-hour lecture. But remember one thing, from the embryo, antinuclear antibodies can affect the formation of the embryos and also can give a pregnancy losses. At the same time, you see this cascade which is getting formed, this intraplacental complement cascade activation that can happen because of the various coenzyme activation, natural killer cells and the interleukins getting activated and can give a losses. Now, what is the treatment options for these losses? One, we all know low molecular weight heparin or aspirin. Is the progesterone treatment? Yes, especially the dydrogesterone, because dydrogesterone can give an immunomodulatory role. It works in immunomodulation of certain cytokines, and it will decrease the natural killer cells. It decreases the neutrophils, and it may help by causing a shift into Th2 immunity. GCSF, this is very new. Actually, I also saw that because I never used GCSF, but they say that GCSF may help in decidualization and leukocyte recruitment and differentiation. It may cause angiogenesis as well. That's why for the refractory endometrium, many of us use it. But most important thing is aspirin or low molecular weight heparin, which will help us in stopping the pro-inflammatory cytokines. And they are the evidence which will help in patients with the immunological losses. About the endocrine factors, may account from 15 to 60%. Diabetes, thyroid antibodies, hyperprolactinemia, or luteal phase defect. Now, how does the diabetes affect? Is simply it increases the ROS, reactive oxygen. It causes oxidative stress, and that may cause aneuploidy into the embryos because it may cause disruption in the routine mitotic divisions. And that's why the chances of aneuploidy and missed abortion can be high. With thyroid hormone, yes, thyroid can have an impact on oocytes at the level of a granulosa or luteal cells, which may interfere with the normal ovulation. But I feel hypothyroidism will cause more of ovulatory disturbances and subfertility. But if you see the thyroid antibodies, TPO antibodies, there is association and a contributing factor with the RPL, and it needs a treatment, or you must do further studies when there is a TPO high antibodies available present in those women. While subclinical hypothyroidism or a hyperthyroidism may not have any contributing factors to it. Going to the luteal phase defect. Luteal phase defect, yes, it may cause subfertility or infertility, but sometimes because there is a decrease in a progesterone, there is a defective decidualization, and that may be the reason why a patient may have habitual abortions or infertility. But at the same time, remember one thing, that because of the decreased progesterone production, there is chances that patient can have an infertility also. Now, if you see this PROMISE trial, why I got it? Because nowadays we all talk about luteal phase, and when we don't have any reason, when it is an unexplained recurrent pregnancy loss, everyone start giving the patient progesterone supplementations. So what does the PROMISE trial in 2016, it has been published, and they said first trimester progesterone therapy with the history of unexplained RPL. Remember, I'm not talking about established luteal phase defect. I'm talking about the unexplained RPL. There is no evidence that the first trimester progesterone therapy will help to these women. Unfortunately, unexplained pregnancy losses are the one who lands up in taking preconceptional ecosprin, heavy amount of luteal phase support, and at times even the low molecular weight heparin. Now, the most important is genetic factor. I have removed 7 slides from genetic factor after Dr. Mandakini Pradhan's fantastic talk in my Star Pravaha. So friends, please go to my Star Pravaha. It is there on an Unfurl site where we have done a complete Pravaha on a RPL. And I must appreciate Dr. Mandakini Pradhan, her talk on a genetic factor in RPL. She has simplified so beautifully that no one will keep on doing complicated tests, or no one will think the genetics is difficult to understand. But in 5 minutes, if I have to tell you, remember one thing: genetic may account for 50% of the losses. And you may explain the unexplained RPL if you understand genetic factors. Now, Anecloidy. These are the individuals with sporadic pregnancy losses. And RPL had similar percentage of anomaly detected in pregnancy tissue. So when we study the pregnancy tissue, and if it is an aneuploidy, if it is the defect with the downs or anything, you don't have to bother. This is not going to be a recurrent. But whenever there is a chromosomal rearrangement, whenever there is a inversions or balanced translocation, then 3 to 5% of the couple with the RPL have a major chromosomal rearrangement, usually a balanced translocation, and 60% reciprocal and 40% Robertsonian in that balanced translocation. Very rarely there can be an inversion. And these are the things which you will be studying only with the microarray. And that's why I feel nowadays when we are doing a microarrays, we are able to work out on. So if you see the chromosomal anomalies with the husband or the father, Y chromosome microdeletion or the oxidative stress with the increased free radical. Now, what is importance of it is, and that's why you should do the sperm DNA fragmentation in patient with recurrent pregnancy losses. Sometimes we keep on discussing so much, and it is just a very high DNA fragmentation, and that's why there is some mutation happening, and that's why there is a losses because of the chromosomal abnormalities. So it's very important that one should go and study both the partners to rule out. So genetic analysis of the pregnant tissue. Now, if we are talking about the karyotyping or this is where I little bit differ, and I would like to say genetic analysis of the pregnant tissue is not routinely recommended, but it could be performed for explanatory purposes. This is a conditional evidence by the ISHRE guidelines. But sometimes the patients are so anxious that I like to send this for a complete genetic study, complete karyotyping as well as microarray. Many labs have stopped doing only karyotyping for the products of conception. They do only microarray, but I think both need to be done. And it's important because later it's difficult to explain why the losses have happened. And it may simplify that if we find certain problem, whether it is recurrent problem or whether it was a sporadic loss, it will be very easy to save her further money on testing other investigation or the same parents for no reason. For genetic analysis of pregnancy tissue, array CGH is recommended based on a reduced maternal contamination. And that's what I was saying you. Many labs have started doing microarray, but I like to do both. Karyotyping of the pregnancy tissue, yes, there can be an association, there can be a contributory factor, but no treatment is needed for this. So genetic factor, what is the treatment? Couple with the karyotyping abnormality may choose to undergo prenatal genetic study. So if the pregnancy is going, they can do the chorionic villus sampling and they can determine. And if they find the fetus is affected, they will be terminating. But I think when there are facilities available to do preconceptional testing, and nowadays there are so many publications, unfortunately, this 45 minutes I cannot talk, but there are interesting publications which has come on that. And if you do the IVF with the PGD, you can then avoid transfer or implantation of an affected embryo, and you can select genetically healthy normal embryo and you can give. It's very, very important for all of us to understand and find out single gene disorder, do the PGDs for these patients and then transfer. Sometimes those who can't afford or probably have landed with the IVF consultants who don't do PGD in their lab may give them an option of one of the gamete donation or adoption, surrogacy, anything one can think about, depending upon. We all know that Amir Khan has done a surrogacy because of the RPL. So it is possible that we can think about these options. Thrombophilia and fibrinolytic. Thrombosis of the spiral arteries and intravenous spaces on the maternal side of the placenta can impair the placental perfusion. So what are the tests? I have told you, if it is an early second trimester losses, think about it. Don't think about first trimester losses happening with thrombophilia or fibrinolytic disorder. What we do is factor V laden deficiency, prothrombin mutation, protein S and protein C deficiency, because they are involved in the clotting factors. Compared with the reference population, antithrombin and protein C deficiencies were not associated with increased risk of RPL, but I think it's worth giving this patient blood thinners, because this is the pathway of a fibrinolysis, fibrin degradation products break down the clot formation. So what happens is there is a disruption in the hemostasis and thrombus formation, increase in a coagulation activity, and decrease in the fibrinolytic activity. And that's why the clot has formed, but unfortunately it has not undergone hemolysis or fibrinolysis. And that's the reason why there will be a RPL or the pregnancy loss. So for women with the RPL, what does the ISHRE guideline suggest? We do not suggest to screen hereditary thrombophilia unless in the context of research or in women with the additional risk for thrombophilias. Otherwise, don't suggest. So hereditary thrombophilia, there is a weak or no association. Contributive factor is unclear. That is factor V laden mutation. What about the HLA? There are certain ART consultant in India. I think they found beautiful results or collaboration, and they do recommend. But if you see the genetist, no one will say HLA typing is necessary. I see nowadays many ART consultants with the patient, because usually they land up with the ART consultant and they do HLA typing. Where do we land in a HLA? HLA compatibility is a controversial evidence. There is no contributory factor. And HLA determination in women with the RPL is not recommended in clinical practice. So they say also further that only HLA class 2 determination could be seen in a Scandinavian woman with the secondary RPL after birth of a boy. For prognostic purpose, you can think about doing it. So friends, I don't do HLA compatibility routinely in my practice. Measurement of anti-HY antibodies in women is not recommended. Cytokine testing should not be used. I have seen so many people doing cytokine testing, NK cell activities. They say it is not needed. Even anti-nuclear antibodies in immunological, we studied that, but they still say it has a considered as an explanatory purpose. You can think about doing ANA. Testing anti-HLA antibodies is not recommended, is a strong evidence. So sometimes the lab has started doing so many things. They come with the RPL package. They come with the different all the tests they can do for the RPL, and it becomes easy for the obstetrician to just write to the lab that do all the tests for the RPL, and then patient undergoes huge testing. Please don't do that. Please segregate. Please go to the history. Try to find out the cause with your detailed history and a very good sonography, and then think about what we should be offering to the patient. Where does the intravenous immunoglobulins? This is a meta-analysis which has published very recently in 2022, the role of intravenous immunoglobulin. I think we have a couple, Dr. Raut, who strongly recommend, and they do have their evidences and publication. Frankly, I have not used in my practice intravenous immunoglobulin, but this meta-analysis does say that this IV improved live birth in a woman with the RPL and underlying immune disorder, but caution should be taken before you give this treatment for a reproductive failure. But the weak point of these studies, don't get carried away with the studies. They have included, you should read and you will realize that they are biased studies, limited with the low number and non-randomized designs of the trial. So it's very important that one should find, even in this meta-analysis, I found in a journal of allergy, asthma, and clinical immunology. But of course, it's important that we study all the journals and try to see. But there were weak evidences and probably might have refused by the other journals. Lymphocyte immunization therapy should not be used as a treatment for an unexplained RPL, as it has no significance. So unexplained RPL, lymphocyte immunization, giving heavy doses of progesterone, putting on blood thinners, please don't do that. Immunoglobulins are not recommended as a treatment, a very strong evidence by ISHRAE. Glucocorticoids. Many patients, they receive steroids, but again, they are not recommended as a treatment for unexplained recurrent pregnancy loss or a RPL with selective immunological biology. This is a strong evidence saying it is not recommended, and please. Now, our understanding of the immunogenic pathogenesis of RPL is still incomplete. And further inquiry into the role of immune system in RPL is needed to determine the specific biomarker to predict which woman with the reproductive failure will benefit from this IV immunoglobulin. You cannot say all patients I give and all they conceive and all they continue the pregnancy. One has to, and probably maybe a decade down, when our understanding will improve, we will be able to find out which is that biomarker. And in that case, if I give, I may improve, or in that case, I may not get any results. Till that time, you cannot give a blanket treatment to all. Male factor, there is a trend towards repeated miscarriage in women whose male partner has abnormal sperm. But paternal HLA sharing is not a risk factor. Remember this, both maternal HLA allele type may play a role. So, if he has a Y chromosomal problem or any other problem, you may find it. But most important thing is sperm DNA fragmentation. This is a evidence which says for a male partner, do two things. One is their genetic study, and second, DNA fragmentation test. Infections, no infection agent will give a recurrent pregnancy losses. Stop doing tests for toxo, rubella, cytomegalovirus, decrease ovarian reserve. Now, there is no evidence that decreased ovarian reserve will cause RPL. But remember one thing, women with the decreased ovarian reserve, they behave as if they are in an elderly age group. So even if she is 30 and if her AMH is 0.8, she will behave with the age group of 38 to 40, where the MH will be 0.8. So probably with the decreased ovarian reserve, you have more of a oocytes which are genetically not healthy, and that may be the reason giving a RPL. Celiac disease, untreated celiac disease, even when subclinical, has been associated with the pregnancy loss, and one can think about. Now, unexplained recurrent pregnancy loss, a huge chapter. Most of the couple want investigation to show an identifiable problem that has a recognized treatment protocol. This is a very important word. They keep on moving from one doorstep to another doorstep because they want to find the problem, even if their previous consultant has explained them that all possible causes have been ruled out and this is probably unexplained. But because there is always underlying uncertainty with the unexplained losses, they are always trying to find out what may be the problem and can we have a treatment for the same. If results show no obvious cause, couple may be very distressed, even if statistics suggest that the prognosis is good. I have told you, around 65% of the patient will have a spontaneous healthy baby. They may need a plan for additional support in subsequent pregnancy, like regular visit, regular scan, seeing by the team who are expert in the RPL or by the senior most consultant, giving them a reassurance. All this is very important. And when diagnosed with a problem for which treatment is uncertain, couple will need more information about possible benefits and disadvantages. This is also very important. If you find in a certain problem, but the treatment is uncertain, like you have to explain to these patients then all lifestyle modification. She is underweight, she is overweight, she is smoking, she has alcohol, she has a stressful life. Progesterone, vaginal progesterone under debate. IVF and PGD. So when we can't find the cause, uterus is no problem. There are immunologically, they are negative. Everything is fantastic. One can think about IVF and doing a pre-implantation genetic, select the best quality embryo. Probably you take a hormone control of first trimester in hand in IVF cycles, and that may be the reason you may think about giving a pregnancy. Egg donation and surrogacy, of course, will be the other way. A new algorithm. This is a beautiful, in 2020, discussed by Ralph Pappas and William Kute, a new algorithm for the evaluation of RPL, redefining unexplained miscarriage. Now, why I'm talking to it? Review of the current guidelines they have. Why I'm talking to it? Because if you evaluate with this method, your unexplained, which we say 50% plus, may come down to 10%. So it's a very simple protocol they have decided. This is by the ASRM group. They have taken 1,400 near cases. For normal, in nearly 800, while 600 had abnormal. And they did what was abnormal: parental karyotyping in 4%, uterine anatomy in 18%, endocrine in 7%, and antiphospholipid in 18%. And 57 were normal finding of all. So coupled with 2 or more pregnancy losses, we should evaluate. They said yes. And evaluation including CME on products of conception with a modified American Society guideline will provide a proven or a possible unexplained 90%. This is what I was saying. If I like to take the products of conception and I like to do the study on it, and it will help us. Unexplained miscarriage will be reduced to approximately 10% of the cases. This group should be focused on further investigation. So find out on the products of conception, the testings, and then only in these remaining 10%, you probably will need to do the further investigation. Knowing the cause of miscarriage often provides psychological and emotional relief, as patients often put the responsibility for the loss on themselves, when this is rarely the case. She always likes to take a blame on herself than anything. Adoption of the strategy for the evaluation and management will result in doubling of the couples who have an explanation for their loss and will reduce the cost of a healthcare system. So please try to evaluate, and adopting this new strategy may help to explain. So what they advise it: after the second miscarriage, do the workup, weight checkup, alcohol, smoking, 3D sonography, screen for the immunological test, screen for the endocrinological factors. And if any problem in number 1, number 2, number 3, or number 4, you treat accordingly. Consider prophylactic vitamin D in all the cases. All RPL should be given prophylactic vitamin D supplementation, provide psychological support to all. And fifth one is product of conception for the cytogenetic analysis. In cytogenetic analysis, if you find, let me start from the right side, any unbalanced translocation or inversion, then we need to do the parental karyotyping, do the genetic counseling, and may think about PGT for a specific reason. Sometimes if the patient says, I can conceive very easily naturally and I can't afford IVF and PGS, expectant management can be think of, because not necessarily all 100% will have a pregnancy losses. Depending upon, they will have exposure in 25, 50 or 75% of the cases, and we still may sometimes have a 25% having a normal embryo formation. If the products of conception turn out to be euploid, fantastic. So if products of conception were euploid, then if no identified etiology, then you start thinking about doing DNA fragmentation, parental other karyotyping, luteal phase defect, or chronic endometritis thinking. Also consider hysteroscopy if you feel that uterine anomaly, previous surgery, septum may not be complete, or you are suspecting you want to see the endometritis, you can think about. And if products of conception, if abnormal cavity, endocrine, or whatever it is, you address that. And aneuploidy, no further treatment is needed. She turned out to be Downs, don't bother about it. She will be fine. So monosomy, trisomies may not need any treatment, and expectant line of treatment, assurance to the patient is the only way to treat that. What is important is acknowledge their loss with sensitivity and empathy. Give them a separate cabin and time to discuss with you. The most effective therapy for patients with unexplained RPL is often most simple, and that is psychological support. They believe that you have said it will be fine, I'll take care. If it is genetically, I always tell the patient, if your next pregnancy is genetically normal, then probably I'll be able to help you to continue the pregnancy for 9 months. It's very important. Negative emotions are toxic, just like smoking and alcohol. But it does not mean all with anxiety will have a RPL. And it does not also imply that all tender love care can afford the abortion. You have to face the reality. Also remember one thing, epigenomics. It means the stress at the time when she's ovulating or early embryogenesis. It itself can cause a problem. So it's very important to give her a time for a counseling, take out her stress, try to find the reason, help them, but avoid doing blanket investigations and avoid giving the treatment which doesn't have the evidences for all. I do have many patients where they have taken IV immunoglobulins and all, and still they had abortions. So please don't get carried away with this patient. Friends, I'll lastly appeal you all. I'm going for my Foxy presidential election. The election year is 2023. It will happen somewhere in August, September. And I humbly request you, you all love me, support me, but voting is important. I humbly request you all to vote for me. Thank you so much for your patient hearing. Hi, Bhavna. Are there any questions?
Not yet, ma'am.
Okay, the recording has happened?
Yes, ma'am.
So share the link with us and all those who have registered.
Okay.
Thank you so much, dear. Thank you. Thank you
ma'am.
for your patience. And I really feel for no reason you hear the lecture entire 45 minutes.
No,
Thank you,
it's interesting.
everybody, for
You always
patient
speak very good. Thank you, ma'am.
Thank you.